Okay, so the second sub-theme, the welfare state, so we looked at last time the provision of social welfare more broadly. Mainly the focus was on things like unemployment provision, provision of things like housing, that sort of things to focus on, and also welfare more generally. And like I said, there are then these two smaller, or these two separate, bigger focuses. One is on the provision of health. They have that as a separate sub-theme, because in and of itself it's quite a meaty, quite a big topic. And then they also have separately as well provision of, provision of educational, educational opportunities, and how far they improve, or they widen opportunities at the same time. So, second one, the focus on public health, provision of public health. It's very similar, essentially, to the welfare one in terms of the questions. It's essentially the extent to which healthcare provision improves in the interval period. That's what it would be about the extent to which healthcare provision improves. In the post-war period, the focus, obviously, the elephant in the room, is the National Health Service gets created, the NHS. So the focus then tends to be on how successful the NHS is, or how far the NHS is a complete success, etc. Okay, so as always, we start off with the context in 1918 of healthcare in the country. So the state of healthcare in the country in 1906, before the Liberals come in, is in a rather terrible state. That state itself had been exposed prior to the Liberals coming into power in 1906 by a couple of major reports carried out by some of these sort of social research foundations. And they've sort of shown how in large pockets of the country there was poverty, there were serious issues of malnourishment, and also quite poor health provision more broadly. And so you then start to get some laws introduced, as always, when we've looked at this welfare topic. The Liberals introduced some limited welfare provision after 1906, when their government basically comes into power. And so up to 1918, therefore, the context is healthcare is essentially provided in three ways. The first way is through national health insurance for employees. It's very similar in terms of its operation to the national insurance contributions we talked about for unemployment when it came to social welfare. So remember we talked about how unemployment, the way it works is you paid into a pot, into an insurance pot if you were a worker, and then when you lost your job you get money out of it. The healthcare provision works in the exact same way, in a similar way. Some employees in certain sectors are given access to a national health insurance scheme if they earn under £160 per year. And basically, you pay into the scheme, and then when you're ill, they pay for your healthcare costs. Really, really important though, this only applies to the wage earner in the family. So it applies to the person who's working, not their wife and children. So it's something for people who are poorer, but it's a very limited provision of healthcare. So then the other two places I come to in, if you have private charitable groups who would pay for healthcare for the poor. It might in some cases pay for healthcare, in some cases they actually run hospitals themselves, so you have sort of private charitable hospitals. But they don't tend to be that large in the first place. And so then lastly, the other kind of major provider of healthcare, especially for the poor at this time, are the workhouses. The workhouses we talked about when we looked at welfare, because we talked about how welfare was traditionally provided through the poor law. And so the poor law in the 19th century, they come up with these things called workhouses, which are basically essentially meant to punish people for being on welfare, or rather meant to make them not want to be on it because they're so bad. But actually, towards the end of the 19th century, the workhouses start to develop their own infirmaries, essentially medical rooms, with some limited medical sort of resources and provisions. And actually, the workhouses themselves, in many of these cases, cease to be workhouses and just end up being infirmaries, just not very good ones. So they will look after poor people who require healthcare provision. So again, it's not the quality, the standard and quality of it isn't great. And sometimes the same work, sometimes they remain workhouses but then have infirmaries, and sometimes they would actually turn into like fully fledged, something hospital to an extent, but again, not great hospitals. So, a brief overview of the changes that take place in the period. Again, there are some similarities to the first part of this sub-theme when it comes to welfare, because again, welfare provision it's not like people at the time are thinking about health and welfare separately, but that's how the course separates it. That's how it is. So what happens is, like social welfare provision, there develops a consensus in this period that actually reform was required to the healthcare system. It was generally accepted that the healthcare provision was quite poor and not adequate up to scratch, and people needed more support, and that actually some reform would be required. So specifically, it was agreed that the government should do the following things. It should first of all invest in research and medical training. Secondly, really importantly, it was agreed that the government should organise its own national network of hospitals, which is a big change. And lastly, it should play some kind of role in rationing healthcare. So there is some, therefore, agreement that the government should obviously step in and have some direction of healthcare provision. However, there are disagreements of what that basically entailed in the first place. So you have on the one hand Labour, the Labour Party, who from 1919 onwards begin to officially and fully advocate a free, comprehensive national health service, free at the point of use, nationally directed by the government, essentially what we have now, what they later create. On the other hand though, medical groups themselves, influential ones, they instead support a kind of regional healthcare system where healthcare is brought under the auspices and control of local health authorities, local government, but it is simply governed or sort of looked after by those local authorities. So what reforms actually take place during the interwar period? Like I said, I think one of the most likely question about the interwar period would be something very simply about to what extent healthcare provision improves or how radically this healthcare provision changed, something along those lines. So the first thing that happens, in 1919 the government creates this thing called the Ministry of Health to sort of look after and govern aspects of healthcare provision in the interwar period. One of the things also created in that period is something called the Medical Research Council. The Medical Research Council is created to research the causes of tuberculosis. Tuberculosis, TB, which I think is a respiratory disease, coming out of the First World War as one of the most significant health issues facing the country. It's a widespread problem. So the Medical Research Council gets created in 1919, and what they do is they basically lead to an improvement in the provision of TB sanatoria, or tuberculosis sanatoria, whereby they basically make it compulsory for local authorities to provide TB sanatoriums, rather than to provide those. And so what you get as a result, you could, I think, tie it back to this, though maybe the link is a little bit tenuous, but you could tie it back to it. The number of cases of tuberculosis in the country falls every single year between 1920 and 1938. Again, like, when I see that number, I am myself semi-skeptical. Like, sanatoriums are basically just, from my understanding, they're kind of like hospitals to an extent, but they're not. You do get some health provision. But back then, it's to keep away from people in the first place. And it's almost like a holiday resort as well. Like, you get to like walk in the woods, and it's meant to be like they're meant to be just quite healthy places to stay because like where they are. But even like the idea of it, I'm not sure how exactly they're meant to help people. And so, because especially back then, they didn't actually have that many legitimate medical ways to treat tuberculosis. But apparently it does help. The numbers do fall every single year. So TB, the situation of TB improves. However, things like the Ministry of Health, which I've already mentioned, at the same time, so they could do small things like that. They could basically get local authorities to make TB sanatoriums, but they couldn't make any radical changes to the system. They didn't really have the legal authority or the legal will or the political willpower to make any radical changes to the system as it was organised. And that's evident by their failure to implement the recommendations of this thing called the 1926 Royal Commission. So the government sets up a Royal Commission, basically an investigative report into health insurance and how health insurance is operating. And the Royal Commission publishes their report, and it's basically very critical of private health insurance companies and their role in the system, and actually recommends that the government actually provides healthcare for people via public funds. The government does not implement that recommendation. And the reason they give, actually, so the Minister for Health is Neville Chamberlain himself, of later fame. And Neville Chamberlain basically claims, he literally admits, that the insurance companies are too powerful to take on. That they're quite powerful companies, their influence is quite significant, and they're too powerful to take on at a period where the government was starting to struggle financially as well. And so, yeah, I mean, in terms of those companies as well, those large companies, they basically control, or they dealt with about 3/4 of health insurance. And so the government considers them too powerful to take on, basically, and do not implement those recommendations. Because obviously the health insurance companies would have been heavily opposed to it, because it would have been sort of stepping on their turf and their business. So that's kind of a drawback, or a way in which things don't change. The health insurance system remains in place in the interwar period, and that remains largely unchanged. The most significant act which is passed, the most significant legislation passed in this period, is the Local Government Act of 1929. And that does basically reorganise healthcare on a regional basis. And what we mean by that is the following. It crucially allows, so it basically allows local authorities to, or makes local authorities take over healthcare provision in a local area. And so it means the following. It allows local authorities to take over poor law hospitals and infirmaries and turn them instead into public hospitals. So previously they would have mainly been giving provision for essentially poor people. They get turned into public hospitals, and as a result they're meant to provide healthcare for all in that local area, as opposed to a small subset of people, as opposed to a smaller group of people. And it also makes them responsible for other areas of public health. So local authorities are responsible for providing things like venereal disease clinics, aka sexual diseases, things like children's health, etc. I think even dentistry and things like that come under it as well. And so, in a nutshell, what it basically does is, it means that local authorities can now control health provision within their region, and so as a result they can therefore also provide medical services for the entire population of that area as a result. So, successes then of that, so you have these local authorities taking over health in that area, and there are some successes, especially in places like London. So you have local authorities that start to experiment in the 1930s in some quite innovative ways or methods of preventative health, focusing on things like people's diets, on their hygiene, etc. And then you also get kind of a couple of examples of local authorities or areas with some really interesting experiments or health centres that they create. So you've got experiments in Peckham and Finsbury. So in Peckham you have the Pioneer Health Centre gets created, and they have this scheme whereby they allow residents to pay about 1 shilling a week for access to an annual health checkup, and they also give them access to leisure facilities. And so you get about 1,000 locals, again, it's always these sort of urban slum London areas, signing up for this scheme. You also have really kind of one of the most impressive examples of local authorities and how they kind of tackle healthcare provision in the area is the Finsbury Health Centre, and that's in North London basically. So the Finsbury is basically a Labour-controlled borough, and so it's this Labour-controlled borough in a really densely populated urban environment, not very wealthy either, quite a lot of sort of lower income people living there as well. And the model in the Finsbury Health Centre basically is one which it's the model that's provided for the future NHS architects. And so what this Finsbury Health Centre does is it basically provides a free range of services. They provide a range of healthcare services which you'd expect in a hospital, and they're all free of charge. They're all in the exact same hospital. So previously you'd have different healthcare provisions or services provided in a range of different locations spread out across an area. They provide them all in that same health centre. They're all in the same building, they're all free of charge, and the centre itself has a really modern, very open design. I think actually they got rid of it maybe a couple of decades ago, well maybe not, like somewhat recently it was kind of taken down. But I think I was reading something about how the current kind of replacement for that hospital kind of looks more grey and dull than the original one built in 1938. So yeah, it's built in 1938. It's a really kind of good example of a authority providing basically healthcare services for the local area quite well as a result of the Local Government Act, basically. However, those are local successes, and being a local change, there is strong regional variation, and there is strong regional, sorry, actually I'll come back to that point before that. You can also suggest, there are some numbers that suggest that actually overall health across the country suggested that public health was actually improving. So this is a kind of a measure of public health which you'll often see used, child mortality or infant mortality. So actually infant mortality drops from 14.3 deaths per 1,000 births to 12 in 1,000 deaths in between 1910 and 1938. So there are some measures of public health across, sort of measures of public health in terms of the statistics that suggest that public health was improving over this period, which again you could attribute to government reforms. However, that's what I was going to come back to. As is always the case in this course, and it's such a common point we constantly keep referring back to, there is strong regional variation in terms of healthcare provision and the situation surrounding healthcare, like there is for everything in this course. So you have a situation where by 1929, less than half the country is actually insured against illness, and those without that insurance have to base it sort of that is state-provided insurance. Those without it basically instead have to rely upon private health insurance if they can afford it, and actually even those who can afford it, sometimes there's actual health insurance schemes that they can afford. They're basically provided by these things called friendly societies. They're basically much smaller providers. So we talked about, if you remember I said that 3/4 of health insurance is provided by the big companies. The rest is taken up by essentially these smaller friendly societies. They're really small in size, and so people in some of the most deprived parts of the country either couldn't afford insurance of any kind full stop, or if they could, it was health insurance provided by these friendly societies. And these friendly societies themselves, like they're very small, and so usually those insurance companies didn't actually have the finances to actually cover your costs, so they would give you some money to help with your medical costs, but it actually wasn't enough in a lot of cases. And sometimes these same friendly societies, they were so, their funds were so scarce that actually kind of go bankrupt themselves and no longer exist. So essentially we're relying upon things like friendly societies that don't really have the ability or the means to properly provide people with insurance payouts. And so what you find that the numbers are quite stark. Again, these sort of regional comparisons. So if you look at things like premature deaths and illnesses, they are higher in places affected most by the depression, like Tyneside, for example, in the north. So if you look at Tyneside, infant mortality rates are 50% higher than in London, right? Which is a huge difference. It's unreal. And that's just comparing Tyneside, which was the worst place in the country, to London, which was the best. But then even if you compare other industrial areas in general, compared to the national average, so we're not going to comparing the worst to the best, but other industrial areas to the national average, they tend to be, they consistently, premature death and illness consistently is higher in industrial areas compared to the national average in England and Wales throughout the 20s and the 30s. So the numbers again show how there is quite significant regional variation, and it's because of the factors that I've already kind of explained. Additionally, despite the provisions of the Local Government Act, so we talked about how the Local Government Act basically gives local authorities, or essentially orders them pretty much, to take over poor law hospitals and infirmaries and make them into proper public state-provided hospitals that are of a good standard. That conversion, the government doesn't actually force them to do it, and they don't also set a timetable for it either. They don't say you have to do it at this stage. So what happens actually is by the end of the 30s, by 1939, the number of the conversion of workhouse infirmaries into state-provided hospitals is actually very slow. And so by 1939, only half public hospitals outside of London were still actually poor law infirmaries. And so despite that Local Government Act, poor law infirmaries, and so this is an area in which things do not change, continue to provide or be a means for provision of healthcare for a lot of people outside of London throughout the country. And then these are places that, again, we said that they're not particularly good. They're really overcrowded with a lot of elderly patients, a lot of patients with sort of long-term chronic illnesses. So you've got these improvements taking place in, for example, Finsbury, but actually if you leave London and you go to the rest of the country, large swathes of it, you've still got this kind of old network and system of hospitals that have not really improved much. So similar to when we looked at social welfare more broadly, although we talked about how there was a will by the government to improve the situation, and clearly you can see the government taking steps to improve the provision of healthcare, the process is a slow one that still has a ways to go by the end of the interwar period. The Second World War is basically where things start to change. I will say as well, so you can get a question that specifically asks you about 1918 to 1939. If it cuts off at 1939, I would not mention this point. Sometimes though, I think you could get a question that goes all the way up to 1945. So if it goes 18 to 45, you can also mention this point as quite a good one, and it's relevant for that question. So the impact of the Second World War, like everything else we look at, is crucial in leading to the establishment of a national health service. So in 1939, yeah.
How likely is it that they will ask us the question 1918 to 39? Because I haven't seen it.
What, for healthcare?
Yeah.
I think very likely. I mean, they're not a glut of points you can talk about. What I think the trouble is with that topic, the interwar period for healthcare, I think the healthcare provision itself is quite confusing. Because there's this big system of, this quite complex system of sort of local hospitals, the private healthcare system that's involved. I think it's a more confusing period. That's where I think it's a bit trickier to answer it. That's why I just sort of prepare for that question by just kind of like just thinking, right, what are 4 or 5 points I can mention if that question comes up? Because I think it's quite possible. Because like if you look at the points, there are clearly enough things you could talk about.
Yeah.
So I just think in your head, just think of, right, what are 2 points I can mention about healthcare does improve or does change, and 2 ways in which it kind of stays the same or doesn't improve particularly. It's a tough question, but you can. It's doable, I think. And I want to try not to get too bogged down in the intricacies, and that's where it can get really confusing. Is, like I said, knowing exactly how the system works and what poor law infirmaries are and how the insurance system works. You don't have to know it in masses of detail, so just don't get bogged down in how all that works, especially if you're finding it quite tricky.
Yeah.
Like I said, you could get 18 to 45. If that comes up, you can mention this point, which is another quite good one. So, the really big change, and this is really the forerunner to the creation of the National Health Service, or the NHS. The government, when the Second World War breaks out, obviously because the nature of the challenges the war is going to bring about, in 1939 they basically set up the Emergency Medical Service, and it's basically designed to provide first aid and other medical services in anticipation of people being injured in air raids. So the government knows what's going to happen in the war, anticipates that you're going to have quite a significant number of injuries kind of increasing during the war. And so yeah, it's anticipation of that. And crucially, the government is basically allowed to, the central government that is, to take over and run all hospital activity. And it's the first time that the government has such comprehensive and significant control over healthcare. And so the government takes over these hospitals and actually, like many other things they did in the Second World War, do a good job. And so the success of that service leads to William Beveridge, so again, going back to that previous sub-theme, we talked about the Beveridge report. The success of this scheme convinces Beveridge, or at least Beveridge calling for a national health service in his Beveridge report. And so again, the quality of organisation which the government sort of brings about when they take over the hospitals and the funding that it brings with it, it helps to, during the Second World War, turn people's kind of opinions and kind of turn consensus within the medical profession itself in favour of a national health service. So if you remember, we talked about how in the interwar period, the health profession itself they believed in some kind of state intervention, but they weren't convinced about a sort of a central, comprehensive national health service, like, for example, Labour were as a political party. And so, yeah, the organisation of the hospitals during the Second World War itself convinces medical professionals themselves and helps to bring them on side to an extent in favour of National Health Service. And so if you get a question about healthcare improvements from 1918 to 45, then you can mention this point. That's an extra point you can mention. It's quite an easy one as well. But just watch out. I think if it cuts off at 39, don't mention this one, so I don't think it'd be considered valid. So you have this. It's kind of considered the forerunner of the National Health Service. So I'm going to briefly go over the creation of the NHS and also its aims and what it's meant to provide. The aims and what it's meant to provide in particular, I think, are quite useful, as I'll go into in a second, because it helps you answer other questions. So, by the end of the war, as I said already, there is a consensus among those in the profession, but also among politicians in general, that a national health service should be provided, crucially, by the state and funded through general taxation, not some kind of insurance scheme that you basically pay into and get services from. So it's meant to be funded through general taxation, and crucially, both Labour and the Conservatives, and this is why I keep saying about the sort of the post-war period in terms of Labour, a Conservative government would also have bought a welfare state. Both Labour and the Conservatives had promised in 1945 to provide a national health service in their manifestos. And so Labour put in charge of this a left-wing minister called Neuer Bevan, and he's basically put in charge of creating a health service. And so they passed the National Health Service Act in 1946, and which basically creates or establishes a national health service. And it's established upon the following principles. And so what I'll say is, I'm going to go into these principles and also what the health service was meant to, with the structure in terms of what it was meant to provide. And what I'll say is, these principles can be really useful to consider as criteria for judgment when given a question about the success of the NHS. I think for a lot of topics, especially if you're aiming for that top A grade, you obviously need to have some kind of useful criteria for your judgments that you're making either in your paragraphs and your conclusions. And I think for a lot of topics, it can be somewhat difficult to think of really good criteria. You can find some criteria, but really strong ones, it can be quite tricky. I think if you've got a question about the success of the NHS, I think for me it's a no-brainer that when thinking of criteria and making judgments, I would refer back to its aims and principles. I think it's a really easy way to judge its success in a very sophisticated way. It's not very difficult, and I think when I've read essays, I've read kids' essays who talk about the success of the NHS in a very kind of like vague way. Okay, the NHS does the following, and this improves. But then how they do the judgment is quite weak, and then you see some cases where they link it back to some of these principles. So, those principles are the following. One, that the healthcare would be universal and available to all. The main idea behind that, of course, being that lots of people don't have adequate healthcare. So it's going to be universal and available to all. The second thing, this is really important, another kind of important to consider when it comes to judging success. For example, we're going to talk about mental health care later. That would be an example of how you'd consider this principle. It is meant to be a comprehensive health service. The NHS is meant to provide curative and preventative care, right? So cures for your diseases or whatever, or for your problems, and things to prevent it in the first place. Additionally, it's meant to provide both physical and mental health care. It was explicitly stated that the NHS would provide mental and physical health care. Additionally, it's meant to provide a range of services, so hospital care, GP surgeries, dental care, and other specialist services. So it's meant to be a very comprehensive system that caters for all sorts of medical needs. And then lastly, of course, it's meant to be paid for free at the point of delivery and be paid for through taxation rather than insurance. I think the third one can be quite tricky to use as criteria, not able to use it. I think the first two in particular are quite easy to use. So just briefly, kind of in terms of its creation, I don't know what question this would be useful in, but I suppose it's worth knowing. On the eve of the NHS itself being founded, they were really actually in crisis, and they were actually potentially facing a significant problem. whereby Bevan himself was struggling to get many doctors to actually cooperate with him. And so you have a situation where you could suddenly be creating a national health service with not many doctors willing to actually work for you. And so in return, he responds by making major compromises with those doctors in the first place. Right off the bat, the NHS is actually created with some compromise. The first thing is that healthcare consultants were allowed to continue working privately on the side. They can basically work in an NHS hospital or whatever, and at the same time have your own private office or clinic where you can basically get paid privately. And the second thing, that GPs would not be subject to local authority pay controls. And so as a result, 90% of all doctors joined the NHS. So that policy was successful, but the phrase that he often used, the phrase that he used as a result was that he stuffed their mouths with gold. He basically had to bribe them to do what he asked. And so you could argue right off the bat that the NHS was created on the basis of a compromise. So the actual structure which is created is as follows. It initially was meant to provide 3 tiers of service. So they basically provide hospital services, so that basically involve A&E services and treatment for serious illnesses, what hospital basically is these days. Secondly, it provides primary care. Primary care are basically things like GPs, dentists, opticians and pharmacists. Having said that, all of these all operate as independent contractors. In other words, they operated like private businesses. And lastly, of course, it would also provide community services. So that's basically health visitors, vaccinations, health education for the community, provide midwives, ambulances, etc. And these will all be managed by the local authority, not directly by the central NHS itself. So what I'm going to run through basically are what the impact of the NHS basically is, and within that, ways in which you can argue it's a success, ways in which you can argue its success is limited, and then lastly I'll wrap up with a couple of major challenges to the health service. So, in terms of the impact on the nation's physical health, you can definitely argue that it was, generally speaking, highly effective in improving the physical health of the nation. However, the NHS treatment reflected the inequalities that existed across society. So you'll find there is a variation in treatment across the class and gender divide. And lastly, as we'll go into as well, aspects of mental health treatment also remain problematic, even though some improvements are made. So, first thing about public health, if you're measuring it. General measures of public health, you can say it definitely is a success. So if you look at most of the kind of like objective measures, first of all, life expectancy. Life expectancy rises for men from 65.8 to 71, and for women from 70 to 77 by 1979. Yes?
Is that just for the NHS, the impact on...
Yeah, so this is basically life expectancy rising after the NHS is created. And so that's a suggestion or indication that overall quality of care has improved. Other measures as well, as a result of the improvements that are taking place globally in terms of combating of diseases, the NHS is able to, because of the fact that things are available free, it's able to take advantage of the global improvements in combating disease because they're able to kind of provide all these drugs quite freely or vaccinations, etc. So for example, in the 10 years after the NHS gets created, in its first 10 years, the number of deaths from TB falls from 25,000 to 5,000, so you can say it's an 80% drop. Wait, 80% drop? 80% drop. And that's due to the new antibiotic drug that is created in that period, which they're able to provide. Additionally, you see mass immunisation programs taking place, so vaccinations are basically given out to people. As a result, you see diseases like polio, the number of people suffering from it drops substantially after the NHS is created. Things like whooping cough, cases of whooping cough dropped by over 90% by 1970. So again, not only life expectancy, but if you look at the range of diseases people are suffering from on quite a large scale or a wide scale, at the turn of after the Second World War, these numbers drop significantly due to the provision of things like drugs on the health service. Yeah.
Is this for 1945 to 79?
Yes.
'Cause what happens like, what happened, what
in between.
what about all the stuff about improving like life-threatening diseases and all that? I don't know if you're close
That'll be that.
to this one.
TB is life-threatening. TB, polio, the life-threatening diseases. So yeah, so life-threatening diseases, the instances of them do drop significantly as a result of the NHS.
Or like smoking and education.
Yeah, you could mention that point as well. So it provides health and education, so they do provide education services and things like these do drop slightly. So you can mention that. I mean, I'm not comprehensively going through every single point. There are other things you can mention. Yeah, I mean, other things that are relevant you can add to this. I'm just trying to summarise it as much as I can, basically.
Yeah.
But definitely, yeah. So again, yeah. So limits to that, though, in terms of public health, and this would actually link on to the next point that I'm going to mention, I think, on regional variations. This is very similar. So those improvements are not uniform across different aspects of care. So if you guys recall, we talked about how the NHS is meant to be a tripartite and comprehensive system of care. However, you find that improvements not uniform. So most funding actually ends up going to hospital care, whereas GP surgeries and preventive health programs remain quite significantly underfunded after the NHS is created, and so you can argue that actually it's not so successful in creating this tripartite system because some kind of aspects of it are underfunded. And primary care, for example, receives less attention as well. Additionally, you also have a regional aspect to this, which I'm going to come back to in the next slide, whereby hospitals in London, for example, are significantly better funded than hospitals in the rest of the country. And just developing that point further in terms of regional variation, as a separate point you could put it, or combine it into that one, the regional variation is quite a significant limit or challenge to its success. You find that actually there's this irony whereby, although it is meant to be a universal system for all, obviously the people who are obviously going to have the worst healthcare provision prior to the Second World War, obviously working class and sort of poorer communities. We talked about places in the north where healthcare provision was really poor and there was no insurance. And what's interesting actually is that actually middle classes are the ones who tend to benefit the most from the NHS rather than working classes. So for example, you've got a fewer proportion of GP surgeries being built in working class versus middle class areas. I think the numbers are something like most GP surgeries in working class areas were built before 1900, and actually I think half of all GP surgeries built in middle class areas were built after 1950. So actually you get things like GP surgeries being built in places that don't necessarily need them. So you find that you've also got numbers that show that you have less money being spent per head on people in those areas. So if you kind of factor, so you basically take the total number spent on healthcare in that region and divide it by the number of people living there, there is more spent per head in middle class areas versus working class areas. And those numbers replicate themselves in terms of the numbers, in terms of healthcare provision. So mortality rates in childbirth. Women were twice as likely to have child mortality rates in childbirth for working class as opposed to middle class women. Sorry, mortality in childbirth. So mortality rates in childbirth is twice as likely to happen for a working class woman than a middle class woman. And so this is something which is often referred to as the inverse care law. It's referred to by somebody who conducts a report or a study into healthcare provision, which basically essentially states that you find a situation in NHS where you actually get better services available in the places which need them the least. That's why they call it the inverse care law. You get it where it's needed the least. So you have the regional variation and the extent to which working class areas get poorer healthcare provision than middle class areas is a limit to the success of the healthcare service or the NHS. Additionally, again, not only is there a gap, there are reports that suggest that actually, or figures suggest, that the gap between working and middle class health provision actually increases after the creation of the NHS. And that's according to this report called the Black Report, and it's conducted by the Department for Health and Social Security. And again, more numbers to kind of chuck in there. They've got numbers like working class women are twice as likely to die in childbirth, middle class women, which we've already mentioned. Unskilled men are twice as likely to die before the age of 65 than middle class professional men. And so the point you can make overall about that is that it's a system that was designed to be a universal one that was for all, but actually in reality it's mainly successful in helping middle class communities who see far more surgeries built in their areas than working class communities do. And so it kind of ends up being more helpful and more successful in middle class communities as opposed to all communities across the country. So next kind of thing you can look at, you can also consider the impact on women and successes in that sense. And so the NHS does also provide women with better control over their fertility, and this is something which, when we look at the topic in terms of women, that's sub-theme 3b, you can use some of these same points to help flesh out some of the points in that when you look at women's personal freedoms. But this focuses more on healthcare. So it gives women better control of their fertility, and so you see a decline in birth rates. The NHS provides things like education for women in terms of education and guidance about contraception, and from the 1970s onwards, the NHS begins to give out contraception for free to women, so that helps result in decline in birth rates. Additionally, you have abortion being legalised in 1967. However, that arguably has a mixed impact. Again, this is the point you can mention in the 3b sub-theme about women, but it's also kind of partially relevant here. So you have a situation whereby to get an abortion on the NHS, you basically require the approval of two doctors, who in most cases are usually male doctors, and would therefore very often reject women's claims. And therefore what tends to happen is, to get an abortion, even after it's legalised, you very often have to go to the private sector for it to take place. And if that's the case, it's mainly middle-class women who are able to get abortions. And so you have these impacts, but they have a mixed effect, and they end up kind of, again, leading to this increased class inequality and division in terms of who's got access to what. Additionally, one other point on that, you've also got a situation where NHS procedures themselves actually remain quite dangerous. So you've got about 86 people dying between 1968 and 1978 as a result of NHS abortions. So the impact on women is basically a mixed record. The final aspect of it that I'm going to deal with then is the impact on mental health. And this, I think, is a really, really good point to talk about, because, again, going back to those aims, which we talked about at the beginning, it links really nicely to a discussion of the aims of the health service, or the NHS, and how far it achieves those. One of the aims we talked about, of course, was to provide both physical and mental health care. And so in one sense, there is some success in treatment of mental health issues, and it's mainly in terms of the attitude towards them, and kind of at least an approach to try and improve the situation. So what you have is, you've got the 1959 Mental Health Act being passed. There are a few changes. The two main changes that are implemented. First of all, you have new terminology being used to refer to people as mentally ill rather than insane. So obviously that kind of links to the stigma which is kind of attached to them. Additionally, people previously, when they had mental health issues, would face judges. Instead, they would now face tribunals. And that would basically remove the stigma towards them in terms of the naming, and the tribunals would also tend to be more sympathetic towards the patients, and would sort of, in their kind of decision making, would seek to kind of always keep in mind the patient's liberty and personal desires as much as they could, as opposed to judges. Additionally, you also kind of have a commitment to providing more optional open door care, as opposed to simply being forced into long-term care. So previously you get a situation where if you were deemed to be mentally ill or insane, you'd kind of be sent to you'd be sort of sectioned off into sort of more long-term care where you would really have the options of what you were doing. So there was a more flexible arrangement in terms of what was available to people suffering mental illness. And so what you can definitely say is that the attitude, at least from the government, definitely begins to shift towards a more caring model, as opposed to one that has sort of stigmatized people. And so that can definitely be said, but obviously, as you see now, there are some limits to that. The actual care itself is found to be wanting. The care itself is found to be wanting. Despite the attempt to try to sort of remove stigma by changing the terminology being used to describe people, stigma toward mental health continues to persist. Additionally, the situation in facilities that kind of deal with mental health continues to be quite shocking in a range of ways. Abuse and misconduct is widespread, and you've got about 25 separate inquiries that take place into abuse and misconduct at these hospitals, and that's basically kicked off after this News of the World report basically exposes some of the behaviour which was taking place at this hospital in Cardiff, which they basically refer to as being inhumane and cruel treatment, is the phrases they used. And that kind of sets off this kind of chain reaction of reports and investigations into the state of mental health provision, which ends up being quite poor in a range of hospitals. So the actual provision itself is quite poor in a range of areas. Additionally, it's not enough. The numbers show that only a small fraction of the required places in hospital and daycare were actually available. Therefore, with the hospitals not having enough places to care for people, what ends up happening is you find patients therefore being admitted into non-specialist hospitals, and so they don't actually receive the care they require. And so the overall point you can make about that is that despite there being the beginnings of a change or the beginnings of an improvement in attitude, the quality of care itself continues or remains poor throughout this period. And like I said, you can really link that quite nicely to the aims of the health service in terms of being, in terms of having to provide both physical and mental health care. And that can be used as a very good way to kind of judge that or make a criteria judgment from that point. So, last points I therefore mentioned, so those are the points specifically about impact of healthcare. You can also refer to challenges to the NHS as way, in terms of a question about how far the NHS improves or how far it's a complete success, you can use points related to its challenges. And because in many ways the NHS ends up being a victim of its own success. When you have these effective hospitals and what they're able to do, that ends up leading to an increased expectation. And you also have a situation where the longer lives that result from people being cared for better, those medical advances themselves increase the scope of provision and also brings with it a significant issue of cost. So, as I mentioned before already in terms of the improvements, there are a range of discoveries of things like vaccinations, and there is an increased availability of them. And that as a result leads to increasing costs. If you consider, for example, 1939, the only routine vaccinations you would be given were for things like smallpox. By 1964, you've got a much larger range of vaccinations being given for things like polio, TB, etc. And they're all available free of charge. Right? That's obviously going to get, that's going to bring with it an expense in terms of the massive increase. Additionally, those same drugs are becoming increasingly expensive. And so what you find is that by 1964, the NHS was therefore spending 250% more on drugs than they were in 1951. Yeah.
Is this a negative?
Yeah, you could say this is a way which perhaps wasn't so successful due to the increased costs. Or the increased cost was a problem with that. However, on that same point, where you kind of reject that point, early on the NHS was rarely a political issue. And by that we mean that both Labour and the Conservatives were fully committed to it, and there was very little difference of opinion across the political spectrum on that point. And so public consensus in support of it was actually very strong. And so as a result, funding was never really a problem despite the increased costs. However, that same problem does not go away. The increased challenge of cost continues to spiral out of control in the 60s and 70s, arguably out of control. Yeah.
What does that bit mean? Why is that a bad thing?
The worst should be gone.
Because it's expensive.
Yeah, exactly. Exactly. It's in and of itself, it's not a bad thing, but the cost it brings with it potentially is a problem.
Yeah.
Okay. So, yeah, the same issues in terms of cost begins to, the challenge kind of continues to get worse in the 60s and 70s. So you've got a situation whereby, as time goes on, again, medical advances are beginning to get better and better. So you have this range of factors that are making costs really spiral out of control. So you've got, first of all, you have newer procedures and forms of surgery that are kind of being discovered and kind of increasingly available. And so to carry those out, first of all, you need new equipment that's really expensive, really expensive, high-tech equipment to actually carry out these surgeries in the first place, or operations. Additionally, not only do you need the equipment to do it, you also need highly trained medical professionals to actually carry out those procedures in the first place. And then not only that, so you've got the expensive equipment and the training, those procedures themselves often have quite lengthy aftercare periods. After you have an operation, you've got lengthy stages that go after that. And so things like increase in provision of surgeries and major surgeries massively increase costs. Then to make that even worse, you've got the number that are acquired also increasing because you've got an aging population, because healthcare is improving. It's kind of this wicked cycle. Your healthcare is improving in the first place, which means people are now living for longer, and that means you've got more people who are older who need more medical care. And so it's this vicious cycle where actually, by improving, you're actually making your costs even worse down the line due to the improvements from healthcare provision. So what you find then is that NHS spending increased in this period by 50% more than was initially predicted. So what we mean by that is they had their initial government predictions of between 1960 and 1975, costs will increase by this much every single year. The actual rate at which the costs increased was much higher than was initially expected. And to make that even worse, that comes at a time when economic growth was really starting to slow down. This is if you look back at the economic sub-theme, this is at a time when economic growth is really starting to slow down, and the 1970s crises in terms of, well, you can look back at that topic, you've got crisis in the economy in the 1970s, and so costs are starting to spiral out of control, arguably, at a time when the economy is now starting to tank a little bit. And so with that kind of brings with it those issues as well, where potentially it's going to kind of create a long-term problem over NHS funding. And so yeah, that issue over cost, the way you kind of make it is that in and of itself it's not a massive problem, but then at the same time the NHS might have these successes in terms of its healthcare provision, but is it in the long term becoming something a little bit unsustainable given how it's changing or given things that are occurring? So in terms of kind of overall success, we can therefore see that there are clear-cut improvements in a range of measures of public health, things like mortality rates, the instances of various diseases, but then at the same time, the attempts to try and create a comprehensive system was intended, but certain things persist that undermine that. So, for example, regional inequalities persist in the provision of healthcare, as do failures in areas such as mental health. And lastly, of course, you can say that the increased cost of that provision casts this shadow over the potential long-term viability of the NHS's funding going forward. And so those are any of those sort of conclusions you can sort of pick out when considering the success of the NHS or its creation as a result. So that's a wrap for that one.